Okay, so this video is going to talk about chronic illness and end-of-life care. Disclaimer, it's kind of a sad subject. So, like I said earlier, the majority of our population is aging, and they are developing chronic illnesses. So what is a chronic illness? Well, chronic means anything that's 3 months or longer, and it's generally a non-reversible pathology characterized by slow, progressive decline in normal physiologic function, permanent with cure most not, most unlikely, and requires long-term surveillance and leaves residual disability. So 7 out of 10 leading causes of death are chronic illness related. They're health illnesses that have required long-term management. So if it doesn't interfere with your ADLs, most people do not count themselves as sick even though they have chronic illness. But when it does, then they do. So approximately 86% of the $2 trillion that are spent on healthcare are for chronic illnesses. Why are chronic illnesses on the rise? Well, because so many people are aging. We have longer lifespans, we have improved screening, we have prompt and aggressive management, and we, aren't the healthiest either. Our lifestyle factors, such as overeating, smoking, our chronic stress, our sedentary lifestyles, all of these things help increase the risk of a chronic illness. So what are some characteristics of the chronic illness? Well, chronic illnesses affect the whole family. It's not something that just affects the patient. It affects the whole family. If you're the provider for the family and you get a chronic illness such as heart failure and you have exacerbations that require hospitalization, then that family has lost their income, their source of income. There's more to manage than just medical. So if you have a chronic illness and you're poorly educated, you don't have a lot of financial resources, then there's more to it than just saying, hey, take this. There's different phases of your illness. You can't keep chronic illness under control without adhering to a therapeutic regimen, which we talked about why that's so important in the last video. Generally, one chronic disease leads to another chronic disease. If you have high blood pressure, you're at risk for developing heart failure. It can be expensive. Generally, it needs to be collaborative to be managed. There can be ethical questions that are raised, and you're living with uncertainty. You know that you have a chronic illness, but you don't know necessarily, what's going to happen tomorrow, because you might have an exacerbation of your chronic illness, and you might not rebound, and you could possibly die. And that's a scary thought, to have to live with that every single day. So there's 2 types of nursing care with chronic illness and end-of-life care. You have your direct nursing care and you have your supportive nursing care. So direct is just that. It's hands-on, it's skilled nursing care. It's like root care, performing technical tasks, managing medicine, regimens, etc. And then your supportive is just as important, if not more important, than your technical care. It can be ongoing, teaching, counseling, etc. And remember that people have the right to receive care without fearing ridicule or refusal of treatment, even if their behaviors, such as smoking or substance abuse, overeating, are what brought them to this path. They still deserve care and still deserve to be treated as such. So when we have a chronically ill patient, we also need to think about our communication. A person that is chronically ill might have some sort of cognition issues. More than likely are going to have cognition issues. And we may need to repeat the same information over and over and over again before they finally get it. And sometimes they never get it. And you have to learn to be patient with these patients because they can't help it. And it's very important to remember that telling a patient something once is not teaching the patient. Hearing the patient's words is not the same as listening. Again, telling them something once is not the same as teaching, and hearing their words is not the same as listening. We need therapeutic communication, so you will use that so much with somebody that has a chronic illness. And therapeutic communication is not something that can be trained. Like, we can tell you all day long that this is not therapeutic and that's not therapeutic, but until you actually do it and practice it, it's just not, you're not going to get as much from it. So we practice therapeutic communication in the classroom, in the clinical, with other patients, with family members. You need to practice. How are you therapeutic? Well, you want to, sometimes you need to paraphrase. Sometimes you need to clarify. You need to have open arms. You need to have an open posture. Think about your body language. These are things that are part of communication. So, at the end of life, the trajectory of your patient's condition changes and they can't rebound. And because of this, they need to enter palliative or hospice care. Clinician attitudes towards the terminally ill and the dying remain the biggest barrier to care at the end of life. We want to save everybody. That is the Western thought. And you just can't save everybody. It's not possible. And so clinicians don't refer to palliative care or hospice until it's almost too late. And so the patient doesn't get the benefit of palliative care like they should. So what is palliative care? What is hospice? Well, hospice is a form of palliative care. And so many people think that when you're putting them on hospice, you're giving up on them. And that's not true. Hospice is just a different direction of care. To be in hospice, you need to have a life expectancy of 6 months or less. Doesn't mean that they will stop seeing you if you should survive 6 months and a day. There's been people that have been on hospice for years because when you get on hospice, sometimes you get better because they take you off of medicines that they feel isn't really needed, and you only have to take a few. They do a lot. Another requirement to be on hospice is to only do comfort care, no life-prolonging therapies. Now, palliative care, hospice care, both do not resuscitate, but with hospice, you only want comfort care. And with palliative care, you can still have life-prolonging therapies. So, like an example would be if you were on hospice and you were having an exacerbation of your heart failure, and so you were very edematous, they would give you Lasix to help decrease your shortness of breath, to help your edema, so it's more symptom management. But if you were just palliative care, then you could have more invasive therapies, like maybe an echo or a TEE that you wouldn't get with hospice. And when you're on palliative care, the time that you should be on palliative care, or that your patient should be on palliative care, should precede the time that the provider actually realizes that they need hospice, because palliative care is broader, and you could be on palliative for quite some time before you actually need hospice. And when there is a relationship between palliative care and disease-oriented treatment, patient and families benefit from this more comprehensive treatment. So it's really an important bridge between the medical bias that we have of cure-oriented treatment and the needs of the terminally ill patient and their families. Nobody wants to be in the hospital and have CPR performed on them in their last days. They want to be home with family surrounding them, and it can just be sad when you know that you're performing CPR on somebody who is not going to survive, but you're doing it because they haven't accepted where they are in their life. All right, so nursing care of the dying patient. So nurses need to know between modifiable and non-modifiable factors. So modifiable are factors that can be changed. So factors that a dying person's previous and current relationship with healthcare providers, that can be changed. The medical management of the illness can be changed. The meaning of the dying person invests in the experience and the resources available. These are things that can be changed. But on unalterable factors, cultural attitudes toward death and dying, gender, what their illness is, these are things that cannot be changed. And so there's 3 critical time periods for the terminally ill. There's the pre-death period, the death event, and bereavement. And pre-death is the need to know. So when you're terminally ill, there's things that you really need to know. Like what is happening to you, and to be able to talk about the reality with someone who will listen, to be allowed to experience the pain of feeling bad instead of hiding your feelings, to participate in decisions affecting how you live your final days versus how you die. And these are things that are not done very well in American healthcare. Family wants to keep it away from the patient that they're dying, or the doctor doesn't know how to have these conversations. So it's kind of an important period, because if you go at it correctly, the patient can hopefully hit the acceptance stage. Then you have the death event. And in healthcare, most healthcare people have seen people die violently, as in getting CPR, those kinds of things. And you haven't seen somebody die naturally from natural causes. So the nurse needs to be present when death becomes imminent so they can anticipate any type of problems, because there's certain symptoms that occur at death, which I'll talk about in a little bit, and the nurse can explain to the family that these symptoms are perfectly natural, because the family might change their mind because of the symptoms that the patient is having. And so when the patient does die, the family should be allowed ample time in private to be with the body. You need to dim the lights, provide warm blankets for the patient, all these things to help the family cope with the death, because you don't want their last image of their loved one to be something that is violent. For example, if it was somebody who had CPR and they were stripped and exposed, you would want to make sure that they were covered up. That's not in this case, because we are just talking about people that are they know that they're going to die, but that happens. And once the death event has occurred, nurses who have been dealing with this patient for days, they need to debrief. It's perfectly acceptable for a nurse to be sad about this kind of event. It's a sad thing to lose somebody, and if you're the nurse of this person, you've become attached to them. You don't just care for somebody and turn it off. You need to have debriefing as well. And then we have the bereavement period. And in the bereavement period, a lot of hospice places actually have a time period where they check on the family, because a lot of family and friends don't want to talk amongst themselves. So if they have a third party that can listen, it helps them deal with the emotion. And your book says up to 3 months, but I know the hospice in Spartanburg actually goes out for like a year to check on them, to make sure that they are breathing okay, and that they're not having complicated grieving, which we'll talk about later. Another thing that's really important with end-of-life care is having advanced directives. An advanced directive is a document that you did while you were of sound mind, or the patient did while they were of sound mind, and it allows the person to document preferences regarding the end-of-life care that should be followed when they are terminally ill and unable to verbally communicate. So that's great. You should have an advanced directive. A durable power of attorney for healthcare is also something that a patient should look into, and that is somebody that can act on their behalf when they are unable to do so. And then a living will is a type of advanced directive in which the individual documents treatment preferences. So these are all things that anybody really needs to have. So you want to provide culturally sensitive care at the end of life. And some cultures value interdependence more than autonomy. So here in the Western culture, we value autonomy. We want to be the boss of ourselves. But in other cultures, such as like the Hindu culture, they value interdependence. So they give authority to a trusted person, albeit usually a male figure in the household or the provider, somebody who has authority, and they rely on that person to make decisions for them. Some groups don't wish to withhold CPR, and they feel that the artificially provided nutrition and hydration needs to be offered. Hispanics and Latino patients, they have extended family that can stay with them while they're dying. If a person is pregnant in this culture, they might not be allowed to attend the funeral. I know when I was pregnant with my first child, a code came in, a pediatric code came in, and I had no problem going in there. I was totally willing to go in there and do my job, but some of the other nurses wouldn't allow me to do it, and that's because they culturally believe that pregnant women should not be subjected to that. So Native Americans, they might want to avoid contact with the dying. So the nurse's job in all of this is assessing, so she or he can help the interdisciplinary team implement what is needed into the care plan. So symptom management. Many patients suffer needlessly at the end of life. And one of those needless sufferings, listen to me when I say that, is clinical depression. It is not inevitable. There is a difference between clinical depression and anticipatory grieving. Please listen to me when I say clinical depression needs to be treated. A patient should not totally withdraw from everything that is clinical depression and not anticipatory grieving. Some patients could have a lower pain threshold and need more pain management. So at the end of life, patients are having to take opioids probably every 3 to 4 hours because of the route. They can't swallow effectively, and so they're having to take sublingual routes. And it's very likely that they are going to die in close proximity to when they received a medicine to help their pain. And we as nurses need to let family know that it's not something that the family did. That's just the way they were receiving their medicine. And if you're receiving your med every 3 to 4 hours, it's most likely going to occur that way. There is nutrition and hydration issues at the end of life. So people at the end of life become anorexic and cachexic. And this is characterized by disturbances in carbohydrate, protein, and fat metabolism. It's part of the dying process. Patients get to the point where they don't want to eat. And it can be distressing for family members because they're not wanting to eat and they're not wanting to drink. But there's some things that you can do to help them out, like offering them food whenever, not just the 3 meals a day rule. Making sure that there's fluids always close by. Certain medicines can help. The medicine dexamethasone is a steroid, and as you will learn, there's a lot of uses for steroids, but there's a lot of adverse issues with steroids as well, and one of the adverse issues is weight gain. So if somebody is going to die within the next month, the provider might put them on dexamethasone. If it's going to be more than a month, the provider won't because it can interfere with protein synthesis. There's also a medicine called Megestrol or Megace, which is an appetite stimulant. And then there is Marinol or Dronabinol, I can never say it right. And it is a psychoactive compound that is found in cannabis, and it can help reduce nausea and vomiting. So anorexia and cachexia may also be seen by the family as starvation, which is just food deprivation, but this isn't the same thing. You don't have an appetite, and your body becomes catabolic. It starts kind of eating itself in a dysfunctional way. And some people want to supplement with tube feedings and parenteral nutrition, but it doesn't replace the lean body mass that is lost. And so it's not really helpful, but family feels that it is because they don't really understand the underlying patho of what's going on. Another thing that occurs is confusion and delirium. Patients, especially towards the end of life, can start seeing family members that have been dead for a long time. They can be alert and arousable and able to communicate, and others could be somnolent. It really is just variable. But if you have delirium, you could have hypoactive delirium or hyperactive delirium. And hypoactive delirium is the kind where you're obtunded and sleeping, and then hyperactive is you're restless and irritable. And again, they might have sleep deprivation, so there is some pharmacy that could help them. There's a medicine called haloperidol, which is an antipsychotic, but it helps to reduce hallucinations and agitation. And then there's benzodiazepines, which can help reduce anxiety. So what nurses can do to help this confusion and delirium is understand why they're having the delirium, and also acknowledge the family's distress. But basically, you just need to reorient the patient. You need to reassure the family that this is the normal process, and keep the patient safe. Monitor for any effects of medicines, decrease stimuli such as lights, TV. Try to maybe find a soothing channel. These are just minimal things that the nurse can do. And then finally, there's dyspnea, which is a very subjective symptom, and it can be very distressing as well for family. But it's a normal process of the dying process. So with dyspnea, some things that we can do, maybe if somebody is dyspneic because of the fact that they're anemic, we might provide a blood transfusion. If somebody is dyspneic because they have severe pain, give them pain medicine, and that will help their dyspnea. So what nurses can do is to help decrease anxiety. So give them their anti-anxiety medicine, do relaxation techniques, guided imagery, treat the underlying pathology of the dyspnea. So if the dyspnea is caused because of heart failure exacerbation, give them diuretics. Give them a bronchodilator if it's because of COPD. Alter their perception of breathlessness, so maybe just giving them some oxygen will help. And then help to reduce their respiratory demand. So teach the patient and family ways to help conserve their energy. And then we have secretions. So as a patient nears death, they are not really able to clear their secretions, and then their breathing sounds weird, and it's not because they're really distressed. What happens is their vocal cords are relaxing, and this relaxation causes the passage of air to sound weird, which causes an audible sound, which can be distressing for families because they think that they're choking on secretions or they're very short of breath, and it's not that they're doing that. So as death approaches, the patient becomes somnolent. They're not able to clear their sputum or their oral secretions, which can further lead to impairment of their breathing. And then there's this phenomenon called terminal bubbling. And the secretions, like family members see the secretions, which is actually more distressing to the family than it is to the patient. So some things that you as a nurse can do is to provide medicine that will help dry them up, like atropine is a medicine that will, as an anticholinergic or hyoscyamine. We can also do oral care to help keep their oral cavity clear. And you can gently suction, but you don't want to do any deep suctioning because the deep suctioning is going to hurt them worse than the gentle suctioning. So the next thing that I'm going to talk about is palliative sedation. And palliative sedation is controversial. And it's offered in some settings to patients who are close to death or symptoms that do not respond to conventional pharmacy or non-pharmacy, resulting in unrelieved suffering. So it's distinguished from euthanasia in the fact that euthanasia is like you're trying to die with euthanasia. Why can't I change my screen? Euthanasia, the intent is to die, whereas with palliative sedation, it's to help relieve symptoms, not to hasten death. It's most commonly used when the patient is exhibiting some type of intractable pain, shortness of breath, seizures, delirium. And before implementing palliative sedation, the healthcare team assesses for the presence of underlying treatable causes of suffering, such as depression or spiritual issues. So generally with palliative sedation, what we give patients are benzodiazepines, which is for anxiety, or narcotics for pain, and it actually can help their breathing because of the fact that you are giving them medicine that will help improve their respirations. So nursing care in the end. Again, it's sad. So nursing care, some physiological changes that you can expect are you have a decreased interest in eating, decreased urine output, not really anything that you need to do about the decreased urine output. They may sleep more. So if they're sleeping more, you can tell the spouse or the family member to try to get sleep when they're sleeping. Increased confusion, So just try to reorient them. Incontinence, irregular and apneic breathing, known as Cheyne-Stokes. So things that the nurse can do is to raise the head of the bed, which can help the patient breathe more easily. And again, remember that the moaning that the patient may exhibit does not mean that the patient's in pain, but really it's just a passage of air across the vocal cords. They might become more restless and start seeing people from the past because their oxygen supply is diminishing, and so the brain is not getting as much oxygen as it should be normally. So you just need to reassure them in a calm, soothing voice that you're there. And implement fall precautions. They could feel hot and cold, so give them blankets when they need it, take them away when they don't. You could sponge their head with a cool cloth. Some patients may try to actually leave their bed, even if they've been in bed for a while. And what the nurse can do is just reassure them, tell them that they can visit with staying in bed. So, after death care, as soon as your vitals cease the patient, you'll start seeing changes. And the changes that you see is that the body starts to be bluish, dusky in color. It's cold, it's waxen. There might be urine, stool that have evacuated. Again, things that you can do is to place warm blankets on the patient so the family member doesn't touch cold hands. You're going to want to clean a dirty patient if family isn't there. You want to go ahead and get them clean before family gets there so that family doesn't have to deal with that. Again, you want to make the room dark and quiet so that family can breathe in the quietness. In certain cultures, Buddhism, there might be chanting. You want to ensure a calm, peaceful environment. The Hindu culture allows a natural death. The client may want to lay on the floor. This is before they die. And then with Judaism, there's a ritual bath that is to occur within 24 hours after death. So we have loss, grief, and bereavement. And grief is very personal in nature, and it accompanies an actual or anticipated loss. So mourning is how the individual, family, or the culture express their grief, and bereavement is the time that mourning takes place. Some people grieve quietly, and some people grieve loudly, and it just whatever their culture says. When a loved one has died, you can have complicated grief and complicated mourning, and what that is prolonged sadness after the death of a loved one, and sometimes the referral is needed for that. And then Kubler-Ross is a huge advocate, or was a huge advocate, and she has the emotional reactions to dying and loss, which are denial, anger, bargaining, depression, and acceptance. And certain family members may be in certain stages. And you have to, as the nurse, will have to deal with all of it. So, as a nurse, you're going to experience death. There is no way around it. Regardless of where you work. So you need to know that it's okay to grieve. You have been caring for this patient for however long, and you have become attached to them, and you need to grieve as well. The only thing about grieving as a nurse is your grief does not need to take away from the patient's family. But it's perfectly acceptable to grieve. So please don't think that it's not acceptable.